Dear Mrs. President, ladies and gentlemen, thank you for allowing us to present the long-awaited results of two randomized clinical trials of fetal surgery in fetuses with severe and moderate left-sided congenital diaphragmatic hernia. My name is Deprest, and I present these results on behalf of 14 principal investigators across 14 fetal surgery centers and 46 neonatal centers from 15 countries across the world. Congenital diaphragmatic hernia is a rare structural birth defect already occurring in the first trimester. It can be diagnosed in the prenatal period. In the majority of cases, this will be in the second trimester. Although first trimester diagnosis has been described, but still it is rare. Its suspicion or diagnosis should initiate prenatal transfer to a center with expertise with the diagnosis and management of this condition for comprehensive assessment, multidisciplinary counseling, and arrangements for timed delivery in optimal circumstances. And as you will hear today, also to discuss the prenatal management. All of this should be before any statement is done on the expected outcome. It starts with ruling out associated problems by genetic testing and advanced imaging methods, because these associated problems have an adverse effect on outcome. In this presentation, we only speak about isolated diaphragmatic hernia, more in particular the most common form of left-sided lesions. Through a surgical correctable defect already from the first trimester, the viscera ascend into the chest where they compete for space with the developing lungs. As a result, babies are born with maldeveloped airways and vasculature, clinically translating into ventilatory insufficiency and pulmonary hypertension. As a consequence, the mortality of this condition remains very high. On the right-hand side, one can see the global statistics from the CDH study group registry, demonstrating that in the last 15 years, the mortality has only marginally decreased and remains around 30%. Survivors may have longer-term morbidities, their nature being nicely reviewed in this paper in the Society Journal Prenatal Diagnosis. The severity of the condition can be prenatally assessed by ultrasound by measuring in a 4-chamber view across the chest, measuring the lung circumference, and express it as a function of the head circumference in the standard biparietal view. The so-called lung-to-head ratio is then corrected for gestational age by expressing it as a percentage of the normal. An additional feature that determines outcome is the position of the liver as either into the chest or confined to the abdomen. For this trial, we used the standardized assessment methods as described in this paper by the European Reference Group, Hernia. Prenatally, fetuses with a lung size of 25% or less of the normal are considered to have severe hypoplasia because their expected survival rate is 20 to 25%. Fetuses with lung sizes between 25 and 45% have moderate hypoplasia and an expected survival rate of around 50 to 60%. Fetuses with 45% or more and with the liver into the abdomen have mild hypoplasia and they have survival chances of 80% or more. The total trial is based on the concept that fetal surgery would improve lung development prior to birth. Historically, this was first attempted by performing an anatomical repair prior to birth to create space for the developing lung. This was abandoned for a variety of reasons, and therefore tracheal occlusion was suggested as an alternative based on observations in fetuses with laryngeal atresia who are born with overdeveloped lungs. Preclinical work focused on the development of surgical techniques as well as to the optimal timing and duration of occlusion. In the early 2000s, clinical trials were done with an external clip and hysterotomy and the first endoscopic techniques. Our group focused on the development of a percutaneous fetoscopic endoluminal occlusion technique using a balloon. In a first-in-woman and later in a phase 3 trial, we demonstrated that survival rates were increased as compared to historical controls. We also demonstrated the maternal safety by documenting the obstetrical and reproductive outcomes in women who had undergone fetal surgery as compared to women who did. In the total trial, we hypothesized that FETO, as compared to expectant management during pregnancy, both followed by standardized postnatal care, would increase survival. These were two parallel trials, one in severely hypoplastic fetuses throughout the presentation displayed in red, and one in fetuses with moderate hypoplasia throughout the presentation in blue. Both had the same primary outcome measure, survival to discharge from neonatal intensive care unit. In the moderate trial, an early morbidity indicator was added, being survival without oxygen supplementation at the age of 6 months. These were trials with a group sequential design. That means with 5 pre-planned interim analyses to stop the trial as early as possible. Computer randomization happened in a 1-to-1 scheme by the Fetal Medicine Center without any stratification. Early experience in severely hypoplastic fetuses informed the sample size calculation, and an anticipated survival increase from 25 to 50% was used and led to a sample size of twice 58 patients. In the moderate hypoplasia, where no data on outcomes with FETO were known, the first interim analysis was used to calculate the final sample size, which was established at twice 98 patients. Next to the intention to treat analysis, a per protocol analysis and safety analysis was anticipated. Roughly spoken, referring tertiary centers who had potentially eligible fetuses with CDH referred their patients to the fetal surgery centers for comprehensive assessment, eligibility check and counseling, and then patients were randomized to either expectant management, and for that they were referred back to the neonatal tertiary centers, or they underwent fetal tracheal occlusion, either in the severe cases at 27 to 29 weeks, or in the moderate group at 30 to 32 weeks, both followed by removal of the balloon at around 34 weeks of gestation, following which the patient was referred back for standardized postnatal therapy as in the expectantly managed group. The fetal surgery technique is explained on this slide. You see an animation and real footage. It is a percutaneous procedure that can be done under maternal local anesthesia. Prior to the surgery, the fetus is also administered medication to immobilize it and provide pain relief. We used throughout the trials standard instruments for fetoscopy provided by Storz and an endoluminal balloon made by Balt, which is typically used for vascular occlusion. There were several exclusion criteria, such as general maternal risk factors for surgery, technical limitations that would preclude fetal surgery, a high risk for preterm birth, psychosocial factors or other factors that would compromise maternal compliance. Fetal surgery had to be familiar both with fetoscopy as well as the fetal procedure prior to their first inclusion, and they had to provide evidence that they had experience with antenatal assessment of patients with this condition. Further management during pregnancy was by ultrasound surveillance, both for amniotic fluid volume, cervical length, membrane separation, lung growth response by lung-to-head ratio, and determination of balloon position and inflation status. We remind you that the balloon is removed prior to birth to induce lung maturation, ideally at 34 weeks or earlier if clinically indicated. This is done either by in utero ultrasound guided puncture, by fetoscopic retrieval using the same instruments and techniques as for balloon insertion, or by removal at the time or around birth, that is either during standard cesarean section while the baby is still connected to the placenta, or after division of the umbilical cord by puncture postnatally. The postnatal neonatal management is according to the EuroCDH consortium protocol. This is a standardized management protocol that was endorsed by the EuroCDH consortium and updated recently in 2015. In the severe trial, 167 patients were screened and eventually 95 agreed with randomization. At the third interim analysis, with twice 40 patients included, the trial was stopped for efficacy. The patients that meanwhile were already recruited but still under follow-up, called overrunning patients, were also included in the final paper. But today we present the results at third interim analysis. When patients did not fulfill the protocol, they were excluded for the per protocol analysis, which will be referred to at the end of my presentation. For moderate hypoplasia, which is more common, 379 patients were evaluated, and eventually 196, or the full cohort, was randomized, equal numbers in both groups, and again, based on deviations from the protocol, a number of patients were excluded in the per protocol analysis. When comparing groups in both trials, there were no obvious differences between the two arms of the study. Maternal age, parity, gestational age and BMI, as you can see, comparable lung-to-head ratios and presence of liver herniation, as you see, quite common, and potential predictors of premature delivery were also comparable between the two arms of each study. The primary outcome of this trial was survival to discharge from the neonatal intensive care unit, which was very significantly increased in fetuses with severe CDH who underwent tracheal occlusion. In fetuses with moderate hypoplasia undergoing FETO, survival was 63%, as compared to 50% in the expectantly managed group, but that did not reach significance. The confidence interval crosses 1, whereas in the severely hypoplastic fetuses, it is clearly above 1. In the moderate hypoplasia trial, the survival until 6 months without oxygen supplementation was a co-primary variable, and again, here one sees that the difference between fetal surgery and expectantly managed groups is very limited. We also measured this in the severe trial. The survival until 6 months was similar as at discharge from NICU, but the difference in oxygen supplementation was less obvious. Important secondary outcomes reflect the side effects of fetal surgery. On this slide, on the severe trial only, one can see that the rupture rates are similar, but here one can see that tracheal occlusion done at 27 to 29 weeks significantly increases the risk for membrane rupture, not only prior to 37 weeks, but also very relevant prior to 34 weeks. And as a consequence, 1 out of 3 of babies will be born prior to 34 weeks when they had fetal surgery. As a consequence, the average birth weight was lower in fetuses that underwent fetal surgery, with on average a 2.3 kilogram. The use of patch was quite comparable, and the use of Ecmo in fetal surgery patients was quite limited compared to those expectantly managed. This is the same way of displaying results, but now for moderate hypoplasia, where FETO was undertaken between 30 and 32 weeks. Despite a later occlusion, the membrane rupture rates were quite high, and 1 out of 5 ruptured their membranes prior to 34 weeks. As a consequence, again, a higher risk for preterm delivery, with 1 out of 5 delivering before 34 weeks, and again, obviously a lower birth weight, but this time, on average, this was 2.5 kilograms. Patch rates were comparable, and the use of Ecmo in these 2 cohorts was similar. The trials were also not powered to allow a statistical analysis of other secondary outcomes that may reflect the impact of prematurity. As one can see, there are no arguments both in the severe group as well as in the moderate trial for differences in outcomes such as occurrence of pulmonary hypertension, bronchopulmonary dysplasia, or hospital stay. For the safety analysis, patients were included based on the actual treatment received. In the severe trial, there was 1 neonatal death which occurred after prompt delivery because of bleeding at trocar insertion, but that baby could not be resuscitated successfully. There was 1 fetus who died because the balloon could not be removed at the local unit. This was in a woman who moved away from the fetal surgery center, went into preterm labor at 33 weeks and 6 days, and presented at a unit that was unprepared for this balloon removal. There were 2 cases of placental abruption in the severe trial, 1 in the FETO group occurring 3 days after membrane rupture, and 1 in the expectantly managed group at around 35 weeks. There was one case of tracheomalacia. This was in a baby that was for a long time on the ventilator, underwent 2 thoracic surgeries for a ventricular septal defect that was not diagnosed prior to birth. In the moderate trial, there were 5 bleedings reported at trocar insertion, all without clinical consequences. There were 2 balloon removal problems. One was actually a minor problem where the balloon could only be retrieved after 3 minutes by the neonatologist, but the baby could be successfully intubated, had a normal pH. It died postnatally at 23 days because of sepsis. There was one iatrogenic death. This was in a baby where the balloon was retrieved by the fetal medicine specialist, although in retrospect, when the baby could not be resuscitated, the balloon was still found at necropsy in the trachea. When going back to the case, apparently the balloon was retrieved under direct tracheoscopic vision, so without a camera, so that no other parties in the room could check airway patency. There were 2 fetal deaths late in pregnancy, one in a fetus where massive thrombosis of the umbilical artery was diagnosed, and one was unexplained. There were 2 instances of tracheomalacia in the moderate group, one where this was an incidental finding at gastroscopy at the time of reflux surgery, and there was one baby that had obvious clinical signs at 2 months of age. Chorioamnionitis occurred in 3 patients throughout the entire trial, all without maternal sepsis. So in conclusion, balloon removal problems can lead to iatrogenic death, and tracheomalacia is rare and may not only be due to balloon occlusion but to coincident other events. As a new surgical technique, we also looked at technical instrument and device problems. In one fetus, the surgeon could not place the balloon. In essence, this was due to fetal position, but no endoscopic instrument failures were reported. Conversely, spontaneous balloon deflation was diagnosed in 6% of cases, either by ultrasound or at the time of reversal of the occlusion. One has to keep in mind that this is a vascular occlusion system that we use off-label, and for its proper use, this has no clinical consequences. The range is as reported earlier. The preferred method for balloon removal in this study was by fetoscopy, in particular when this was done electively. In 1 out of 5 cases in an emergency, the balloon was removed at the time or immediately after birth. Again, there were 2 balloon deaths. One we considered truly iatrogenic because the team could not retrieve the balloon, although trained. In the other patient, it was a compliance problem, and she presented at a location where nobody was prepared to do this procedure. In this study, we came across a number of structural defects that were diagnosed after randomization or after birth, and along the same lines, also some genetic conditions were diagnosed after randomization, most of them obviously postnatal, but also a number of them prenatally. That diagnosis may have affected the further management of the condition, and based on the individual circumstances, these patients were either not or included in the per protocol analysis. These studies have several strengths and weaknesses. To our credit, we must say this is the largest trial in fetal surgery ever. Even if CDH is a rare condition, we were able to recruit sufficient numbers to allow us, with sufficient power, make a statement on the outcome of fetal surgery. It will also provide reference data for future studies. Findings in this study should be extrapolatable because it was a multi-center trial using standardized assessment and surgical methods as well as postnatal management, so the findings should be translatable to a larger setting. The outcomes we observed are very much in line with earlier non-intervention studies, so probably reflect clinical reality. There were virtually no missing data, and for the primary outcome, we had complete data retrieval. There are several weaknesses, such as the duration of this study, nearly 10 years, a period during which neonatal management protocols may have changed or even improved, although that should affect both arms of the study equally. Centers were not blinded to the treatment method. We did not stratify for fetal surgery or neonatal treatment center. At this moment, the medium or long-term results are not yet available, and numbers will still be too low to document uncommon maternal or fetal complications. We accept that there will be criticisms when outcomes are compared to postnatal studies where different case mix and a different denominator is used. Finally, we still had a problem with an ethical controversy at the beginning of the study and a dispute and backdoor phenomenon close to the end. Finally, because today there is no core outcome set for perinatal studies in the management of CDH, so our study findings may be difficult to compare with future studies. In conclusion, these total trials demonstrate that it is possible to perform large, collaborative, even randomized clinical trials in fetal medicine. As to CDH, in severe hypoplasia, our findings add to the earlier evidence for right-sided CDH that FETO significantly increases survival chances. In moderate CDH, the effects were less and not significant. FETO, at whatever time point and severity, has a high risk for membrane rupture and preterm delivery. We did not demonstrate maternal risks of relevance, but balloon removal problems can be lethal to the neonate. The long-term outcomes for this procedure are definitely required to assess the potential impact of prematurity. We also hope by pooling the data that we will be able to analyze the effect of the duration of occlusion when comparing moderate and severe hypoplastic fetuses that underwent FETO at different time points. Other gains in the future may be to the use of less invasive instruments, external balloon occlusion reversal, or the use of medical adjuncts that would either reduce the membrane rupture rate and, for the latter, the effect of tracheal occlusion. As a last conclusion, we would warn that our findings may not be extrapolatable to centers that have less experience with fetal surgery. For those who would like to read up further details, as we speak, the results of these trials are being published by the New England Journal of Medicine. We would like to thank at this moment the Data Monitoring and Safety Committee, our data managers, and expert advisors who drafted for us the neonatal management protocol. On a personal note, I would like to quote the Belgian cartoonist Hergé, who wrote, "When one believes in his dream, it makes them come true." In 1950, he predicted in his Tintin cartoon book, Man on the Moon, that man would effectively walk on the moon. 18 years later, Armstrong and Aldrin effectively walked on the moon. Well, 18 years is exactly the time period it took for FETO to grow into adulthood. From first in women's study at King's College Hospital in 2002 to completion of this trial in 2020. I would at this time also like to thank study participants, neonatal management centers, my fellow co-PIs at the fetal surgery centers, and numerous supporters who have been funding our research towards completion of this trial. I thank you for your attention.
Well, hello, everyone. It's my honor to be asked to discuss the long-awaited results of the total trials that were just presented to you by Jan Deprest. I use this title because I'm often framed as a critic of FETO, and Jan and I have had a number of interesting point-counterpoint discussions at various meetings over the years. But I want to emphasize that no amount of criticism or commentary on my part can reduce the magnitude of the achievement of completing these two well-designed trials on the efficacy of FETO in moderate and severe populations of CDH patients. And I have nothing but admiration and respect for Dr. Deprest and his colleagues. So why have I been a critic of FETO? Well, the evidence for FETO consisted of multiple publications over a 10+ year period. Over 200 patients were accumulated in a non-randomized fashion. There were no true concurrent controls. There was no standardization of postnatal care. In fact, postnatal care for CDH in Europe in general improved over the same period that improving results were being reported in FETO trials. And most importantly, there was inconsistent prenatal selection. There were inclusion of a large number of patients with non-severe CDH, as evidenced by a 30% rate of primary repair in their severe population. As a pediatric surgeon, that's completely inconsistent with my experience with truly severe CDH patients. Despite these flaws, there was increasing investigator enthusiasm and, in fact, bias, with some investigators claiming that a randomized trial of FETO for severe CDH would be unethical. It had been proven to be efficacious, and there was no equipoise. Fortunately, Jan Deprest maintained his equipoise and doggedly pursued randomized trials to prove the efficacy of the therapy that he developed. The risk is obviously dissemination of this technology without randomization, which has happened with many surgical procedures to the detriment of thousands of patients. It's completely understandable. It's a frustrating problem. It's a relatively simple technical procedure for an experienced fetoscopist. There have been good results shown in non-randomized trials. The problem is there was no focus on the downside of prematurity. There was no long-term follow-up of these patients. There was no real focus on neonatal outcomes other than survival. So from the perspective of a neonatologist or pediatric surgeon receiving a severe CDH patient that may be delivered prematurely because he underwent FETO, it's a devastating combination. And there was a real need for randomized trials to demonstrate the efficacy of this technology before it was adopted. So the total trials were a necessity. The first question that I would ask is, did the total trials satisfy what are, in my view, the absolute requirements for demonstrating efficacy of a new therapy for CDH? These requirements are accurate prenatal selection. I think they did a very good job at this, using experienced sonographers from high-volume centers to make these difficult measurements. I think they did as well as can be done. They had contemporaneous controls. Their randomization provided well-matched control groups that were cared for in the same centers at the same time as their experimental group. They did their best to standardize neonatal care. All of the centers had the same protocols, although it's problematic that there were 46 neonatal management centers that varied in CDH volume from 1 patient to 59 patients a year in the 2 years prior to the first trial patient. So it'd be interesting to see a breakdown of how many in each group were delivered in high volume versus low volume centers. I suspect it wouldn't significantly impact the results. So given that they satisfied these requirements, did either of the total trials improve upon the outcome of CDH? And I'm not going to repeat Jan's presentation. You saw that in the moderate severity trial, no benefit of FETO at 30 to 32 weeks was demonstrated, and perhaps risks were increased with premature delivery of these patients. And in contrast, the severe trial demonstrated an improvement in survival that was significant and was sustained for 6 months of age. Once again, there was potential harm done with a significant rate of prematurity in the study, in the FETO group. So questions were raised by both trials, as is true of any well-designed randomized trial. The biggest questions were that neither trial was adequately powered to look at morbidities. And although survival is important in CDH, survival without major morbidities should be our goal. And so hopefully future trials will try to adequately assess improvement in morbidity and prioritize morbidity outcomes over simple survival. And again, neither trial was adequately powered, and follow-up was not long enough to conclude that there was no impact of prematurity. That should not be a conclusion from the total trials. The question of whether a price is paid for prematurity that negates the benefit of FETO needs to be answered. And it's hard for me to imagine that when 65% of the patients are delivered prematurely, there would be no impact on the morbidity in the outcomes analysis in an adequately powered trial. I also have questions from a pediatric surgical and North American perspective on postnatal management. The first relates to the instance of no repair, which is astronomical from my perspective in these trials. So only 84% and 74% of patients in the moderate trial in the FETO and control groups respectively underwent repair. In the severe trial, only 53% and 36% of patients in the FETO and control groups respectively underwent repair. This raises questions about selection in the moderate trial, criteria for repair in both trials, and whether there was investigator bias toward repair of patients that underwent FETO over repair of patients that didn't. Remember, these trials were randomized, but they weren't blinded for treatment arm. I also have questions about Ecmo in the severe trial. Only 2 of 38 patients underwent Ecmo in the FETO group and 11 of 38 in the control group. These are patient populations that had a 60% mortality and an 85% mortality respectively. Why wasn't Ecmo used more commonly? Were some FETO non-survivors denied Ecmo for prematurity and low birth weight? How many in each group were born and cared for at centers that did not offer Ecmo? This might significantly impact results, even improve the results of FETO if Ecmo had been applied. The moderate severity trial also raises the question of did they test the hypothesis? So FETO at 30 to 32 weeks is very late. Experimental data would support an earlier tracheal occlusion for maximum benefit. And so I hope a future trial will address the questions of whether earlier FETO in a moderate severity group would show survival or morbidity benefits. Are the total results applicable to other centers? I think that remains to be seen, particularly North American centers. So there are differences in survival. At CHOP in 2020, during the fiscal year, we saw 51 patients that were evaluated at CHOP and delivered at CHOP. You can see our ODE ratios there, which we're very good at measuring. You can see that 30% of our patients were under 30% ODE, and there was a survival of 65 to 70% in that population. That's compared to a 15% survival in the total trials. It's hard to reconcile those survivals if you're a North American surgeon working in a center like mine. There are marked differences in management related to timing of repair, frequency of repair, use of Ecmo that I could go into but won't. So are they applicable to US centers? I think time will tell, and I think we need to do our own trials of the efficacy of FETO. So my conclusions are that in the context of the total trials, FETO's improved survival for severe left CDH, but not moderate left CDH in well-designed clinical trials. FETO has not been demonstrated to improve morbidity endpoints, nor has it been shown to cause no harm in terms of the consequences of prematurity in these patients. The total trial should serve, however, as a promising starting point for subsequent well-designed trials of FETO. They were able to do these trials, and we should continue to do them in the future. If FETO is applied, it should not be performed outside of well-designed trials performed in high-volume centers with experience in fetal therapy and CDH care. This should not be a green light for inexperienced centers to begin doing FETO. Future trials need to include primary endpoints of morbidity with longer-term follow-up rather than focus primarily on mortality. And finally, the impact of FETO should not be considered independently from the impact of improved neonatal care. Again, it's been an honor to discuss these results. And thank you for your attention.
So welcome, everybody. I can see that people are gradually joining the chat session here. I'm not going to start with the questions just yet because I can see the numbers of participants continuing to go up. But just to say that this is the live Q&A session for the Total Trial Conference. So I'm Lynn Chitty and I'm moderating this discussion. And I'm very pleased to have Jan Deprest, who is the initiator of the Total Trial, the lead for the Total Trial, who's just presented that data, and Alan Flake, who has just done a very interesting critique of the trial. All of you're all muted by default when you enter this session, but it would be really good if you could submit questions via the Q&A, and we'll try and get through as many of them as possible. So we've got nearly 80 people here now, so I think we'll kick off with a couple of the questions that we've got in the chat here. So one question, and I think this relates to the fact that a number of your cases, Jan, had genetic abnormalities detected after birth or during pregnancy. Should we do an amniocentesis or NIPS in all these fetuses, even those with an isolated diaphragmatic hernia?
Well, in this trial, it was actually mandatory to do genetic testing. The nature of the genetic testing changed over time. As you know, it was a quite lengthy trial. So invasive genetic testing was recommended and done. But even if we had done that, there were some post-randomization prenatal diagnosis. And in particular, tetrasomy was picked up twice at least. And then there were some postnatal diagnoses that were more on a syndromatic basis or two structural anomalies that were missed. So the answer to that is the word isolated can only be used if you have done appropriate genetic testing, of course, next to as good as possible structural analysis.
Okay, so would you go as far as exome sequencing for all cases, karyotype, microarray, and exome sequencing?
I think that, of course, will change the scene in the future. I mean, we also saw that even the introduction of array analysis already changed. We picked up, I think, in our own series about 9% of additional diagnosis. So the answer to that is yes, because of course, with an antenatal intervention as aggressive as this one, you really want to operate on a fetus that is having an isolated diagnosis.
And Alan, would that be your practice in the States as well?
Absolutely. I think the thing is there will always be some missed. So because of the frequent syndromic associations with CDH, you're not going to pick up everything, but I think you should make every effort to do as much genetic analysis prior to intervention as possible. And with FETO, typically you have time to do that. You have a few weeks even to counsel the patient, do the genetic analysis, etc.
Okay, thank you. So another question here is, again for Jan, the infant outcomes after FETO seem better than expectant group, but the former group delivered early in relation to the procedure. They want to know what if there's any reason for that, and how is the prenatal observed to expected LHR change after the procedure? So does it,
yeah, so this would be two questions, and I think the first one is pointing to the Achilles heel of this whole antenatal surgical enterprise. And in Dr. Flake's critique, that is, of course, an important element, because we cannot really calculate or take into account the impact that prematurity has in the population that we treated before birth. So I'm sure in large numbers we would pick that up. Again, this study doesn't have these outcomes yet. It needs to be done, but it will be difficult to ever know what the effect of prematurity is given the low numbers. What is the reason for it? Well, it's an invasive procedure. Even if it's only a 3.3 millimeter access, it is a constant thing. It is there even with late or early occlusion. That's the worrying thing. So it's probably something that we will not be able to get rid of very soon, and will always compromise the outcome of the treatment. As to the last question, is there an increase in lung to head ratio? Yeah, several studies have been done to document the change in lung size, whether it's volume or LHR, a two-dimensional measurement. And yes, there is an increase in lung to head ratio, and it was different in both groups, which suggests that the lung growth was not similar, that it was more in the early occlusion group in the severe cases than in the moderate cases.
Great, thank you. And Alan, a question for you. It is about the idea of you replicating the trial in North America. How many patients would you anticipate that would be required to enroll? And that's a question for Magda Sanj-Cortez. So do you fancy doing a trial in America?
I think it would need to be a multi-center trial, obviously. And I think to look at issues of morbidity, I think you're going to require more patients probably because you're looking for softer endpoints with perhaps less percentage of a difference. And so I'd have to do the statistics, which I would hire a statistician to do, but I would estimate that it would take at least as many as were enrolled in the moderate trial, and probably more than that and almost certainly more than that to really nail down the issues of morbidities after CDH.
Yeah, and one of the issues that you raised about Jan's trial, about the total trial, was about the fact that postnatally it's not blind. You're not blinded to the prenatal treatment, and that's another issue, is it not? That would need to be, if you could address that. I think that's going to be challenging.
It's pretty hard to address. Yeah, I'm not sure how you would do it because obviously the neonatologists are aware of the prenatal interventions that have to be. And of course, some of the balloons are removed at birth even. So I think it's almost impossible to blind the investigators.
Yeah. Jan, a question for you. Can you explain the need for Ecmo in the severe trial non-FETO group that was 29% and 20 to 21% in the moderate group for both arms?
Thank you for that question. So I think it touches on 2 points. It's on the use of Ecmo, which was different in both groups. And the logic of that is, of course, that when you have a premature baby, they are overrepresented in the FETO group. When the birth weight becomes that small, actually Ecmo may not be offered to them. I mean, there are different cutoffs at different locations, but anyway, smaller babies may not have could not be offered the Ecmo. So by definition, your Ecmo rates cannot be not be the same. As to the moderate trial, you saw that the Ecmo rates were around 1 in 5. I don't want to do statistics on these low numbers, but in the severe group, in the expectantly managed group, which was of a normal birth weight, it was around 30%. So yes, the Ecmo need in the severe group might be higher, but again, it becomes very dangerous to compare these statistics. But I think it points to the most critical point. If a center considers Ecmo as a very important management tool that can improve the outcome, with fetal surgery, you must know that 1 in 5 babies might be too small to actually offer Ecmo because of prematurity.
Okay, thank you. And a question from Rodrigo Ruano. How can you compare the present results with previous randomized controlled trials for FETO?
Thank you, Rodrigo, for that question. And actually, we must credit you for doing a previous randomized trial. So what we have done is try to work in a relatively homogeneous population, so not mixing left and right. And then we made 2 strata with severe and moderate hypoplasia. And if you look at the outcomes in your trial, which was a mixture of left and right, there was a significant increase in survival. And your, let's say, the expectantly managed group had I think I recall now, about 5 or 10% survival rate. So it was criticized as being a too low survival rate that makes comparison to other serious difficult. So I think it is added information. It's a more homogeneous group. It's more powered. Again, I now take the discussant's element. Is that 15% expected survival rate or the 50% expected survival rate in the expectantly managed group, is that representative of all parts of the world, of all institutions? That's, of course, another question. For the Harrison's trial, yes, sorry, I forgot that. I mean, and this is really very unrespectful for me. Professor Michael Harrison was on the DMC of this trial. For those who do not remember, that was a trial, I think about 15, 20 years ago, where a balloon occlusion was done. Several techniques were mixed. The lung to head ratio that was in that trial was under 1.2, but it was not corrected for gestational age. But what was very remarkable in that trial is that the survival rate was around 70%, I think, in both groups. And they stopped the trial because there was no difference, I mean, for futility, because there was no difference between the 2 groups. And what that trial shows, this is intuitive, if you have a single institution trial, of course, you don't have all the problems that we had with the multi-center design. And that in that institution, indeed, the survival rate was 70%, even if the cases would be, if you would calculate it, one lung to head ratio 1.2 is probably around 30–35% lung to head ratio as we would use today. So indeed, that is a trial that was single institution and gives different results.
I think this just illustrates how difficult it is to translate results from one of these trials to another trial. There are many, many differences that can account for dramatic differences in survival in the outcomes. And those range from your ability to accurately prenatally select, your consistency in that regard, your postnatal care, all of the things that go into picking a homogeneous population and then looking at a consistent outcome. And so I think it's very important. I think the biggest benefit of these trials from Jan are that he proved that they can be done. He proved that you can take a very difficult problem like diaphragmatic hernia, design a multi-center trial, have cooperation from all of the centers and do it very well. And I think it's really a model for future trials that need to be done to answer a lot of the remaining questions about this.
Thank you. So I haven't got any more questions in the chat. I've got comments. Thank you very much for your excellent work. Congratulations on these great studies and your dedication. and great talks from both speakers. Alan, have you got other things you'd like to raise with Jan that we can share with our audience?
Again, I just want to express my admiration for the accomplishment of it. So I'm really not critical. I understand many of the problems that I point out in his trial are very difficult to solve. So one of the issues with this trial is he had so many postnatal management centers, and the experience range in those centers was dramatic. So some of them reported only one case per year in the 2 years prior to the trial. Another one reported 59 cases per year. And so it would be, I think, informative and helpful if the results were broken down a little bit in terms of how many deliveries there were from high volume centers versus low volume centers in each group. Were they comparable? If randomization smoothed it all out, then I really don't think it's an issue. It is not going to change the results significantly. And I imagine that's how it worked, because the high volume centers are the ones that would probably contribute most of the patients. So, Jan, do you have any commentary on that, or will those results coming out more in the future?
So this was a dilemma from the beginning, of course. Rare disease, slow recruitment in fetal trials. So at a given stage, we say we need all the help we can get. About 70% of the population was managed in the 4 major centers. About 80% if you extend it to 6 or 7. We did not do, and we did not anticipate, a stratified randomization, and we did not do a stratified analysis for the same reason, of course. There is a lot of controversy in surgical trials whether you should stratify for the surgeon or the center. I mean, there are pros and cons, and I have a statistician that would spend his life on that. But the stratification would have created 2 problems. Is one, it would have pushed the sample size potentially even higher. And I wanted to finish this before retirement, that's clear. And the second thing it is that you, in a design of a trial where you do multiple analysis and you do block randomization, you have to create blocks for individual centers, and you get the predictable randomization scheme. I mean, all things that are design things. Yes, it's a shortage. We have looked at the data because the DMC did it secretly. I heard afterwards, and they didn't see like trends in survival rate differences. But of course, for the centers with minimal recruitment, this was not looked at. So for your future trial, I think you guys have to decide how you do it and homogenize upfront in the selection of centers.
So we've got a few more questions now. So one for you, Dr. Flake. Based on CHOPS data, very interesting to see the considerable discrepant survival information compared to the trial cohort. What are your size age cutoffs to offer ECMO in these infants?
Okay, so we offer ECMO at prior to after 32 weeks gestation and 2,000 grams in general. Those are our size and gestational age cutoffs. And I just want to state, I meant to state it in my presentation, I didn't present CHOP as any kind of a example or model. I don't mean to brag on our results. I presented it to just illustrate the contrast that there can be between centers and outcomes. And so we're not alone in the United States in those kinds of results. There are a number of centers that are high volume centers that I think the results in even the very low ODE groups are much, much better than the expectant group in this trial. What I want to emphasize, though, is that those results also contain a large amount of major morbidity, very long hospital stays. Survival is not everything by any means.
Absolutely. A question here about, for both of you really, is lung to head ratio the best method to select severe versus not severe cases? And can the variability in estimation of this measure affect the results of the total trial? Good question, I think.
Take that first, Alan. So indeed, it is, I mean, we can be criticized for that. So it became, for that reason, a selection criterion for a fetal surgery center. They had to be familiar with the assessment as well. I mean, some of you know that there is a learning curve in this process, and it has been determined to be around 70 cases. So think about the volume you need in terms of assessment. Yes, there is measurement error. We often have the concept that when you use an alternative technique, volumetric technique, that we may overcome all these limitations, but they have the same limitations. They also have measurement errors, etc. Also for MRI, we must realize that the number of sections at 26, 27 weeks through a lung is very minimal. So this, what we have decided upfront, and all the centers have signed into this, is that number one, we will retrospectively go back to the selection of patients. It is a very interesting thing for future trials, whether we would all agree on the selection. So the images that were used for the selection of the patient and the inclusion of the patient will be analyzed by an expert. And secondly, we will try to, out of this cohort with two interesting unbiased cohorts, we will try to see whether the prediction model using MRI as compared to lung to head ratio, whether it would provide a better prediction. And this is still only using two biological biomarkers, the liver and the lung. But as you know, position of the stomach has been discussed. So we are in need for better prediction models for whatever, even without fetal therapy, but we are in definite need for predictors of things that we haven't even addressed, which is pulmonary hypertension.
Okay, a question from Doug Wilson here. What uterine plugging option can be used to decrease PROM?
I mean, Doug, welcome back in the real world indeed. For 25 years, we have not solved this problem. I'm not so sure. So there are several strategies still being explored. What is very interesting is the observation that fetoscopic access sites that are manually sutured, as they are done for fetoscopic spina bifida repair with exteriorized uterus, those people report very low membrane rupture rates. If you would extrapolate this to another surgery like this one, or laser surgery, if that is really true, we may want to do a surgical effort to close the defect site, which means that percutaneous becomes very difficult. So it's a very interesting question you ask. So the $1 million question is, can you do this percutaneously? Can you mimic this closure thing? And I know about several groups working on it. Everybody has good ideas, but none in the last 20 years has ever worked.
Okay, we've got quite a lot of questions here, so I'm going to be a little bit selective because we will run out of time. So question from Tim Van Makem. The moderate group did not show a significant improvement, but still a 10% increase in survival in absolute numbers. Is that not sufficient to intervene? Where are your confidence intervals?
So that appears that Mr. Van Michem has not reviewed the paper, but he could not because he was one of the co-authors. So in our initial submission, we must say, and I will admit here in public, that we thought that this confidence interval of 0.99 to 1.67 and the 17% increase in was very close to what we anticipated. For me, in terms of survival of the primary outcome, I don't think there is any evidence that we have been harming fetuses. I don't say for prematurity, but for survival. We have the impression there is at least a very strong trend for increase in survival. And it is also biologically difficult to understand. So we need to find out why the difference between the two trials is so big. And we will do so by pooling the data and taking time point of occlusion, duration of occlusion, and lung to head ratio in a statistical model to see whether we can distillate, whether there is somewhere a cutoff between 25 and 45 or something similar, at least if you manage the patients as we have done here, and if we would be managing the same mix of population.
Okay, and a good question here is, how are these results going to influence your counselling? Is your counselling about the prenatal management of CDH going to change in light of these results?
This time I would be keen to hear what Dr. Flake says, and then I will answer myself.
Well, no, I think they will change. I think this is clear evidence of improved survival with severe CDH. Now, we are doing FETO in our center now. We were planning to join Jan's trial and didn't quite get enough cases accumulated. So we've been counseling patients for some time relating to FETO, and we've done 10 patients, and we have 9 survivors in the first 10 severe patients that we've done. Now, remember, our control group has an 80+% survival rate. So, the benefit really depends, again, on morbidities. And in fact, we see in our early data a marked advantage in pulmonary hypertension, and we see a marked advantage in length of stay in the patients that are survivors. So I am becoming a believer in the benefit for severe CDH. I implore people not to apply this to moderate CDH outside of a controlled randomized trial, which I hope we will initiate with earlier balloon placement and focus on morbidities. But the worst thing that can come out of this trial is for a multitude of centers to start putting balloons into diaphragmatic hernia babies and not studying carefully whether it's beneficial or not.
And you just touched on something there about the gestation for intervention. So another question is, should we be offering earlier intervention in the moderate group, given that there was clear evidence for the severe group of an earlier intervention?
That needs a trial to answer that question, doesn't it? So we really need to design a randomized controlled trial on moderate CDH. There are many more of those, and so the patients can be accumulated more quickly. And I hope there will be a multi-center trial in the US run by NAFNet, hopefully, that will address that question.
I can only second that, of course. As for severe, I'm glad to hear that this will be offered as part of the options for parents. I'm also glad to hear that there is, at some stage, apparently also for severe, a decreased morbidity in terms of pulmonary hypertension. If we can substantiate that, we solve one of these very limiting factors for these babies, and then it will become a matter of defining what morbidity outcome do you take to look at the trial in severe, whatever its nature would be. In moderate, indeed, we have already been talking in the consortium, should we go earlier? And then comes the question, how do you design such a new trial? So would you do it earlier and compare an expectantly managed group? Because if you're going to compare to early to late occlusion, I mean, the difference will be so small that this will be a trial that numerically becomes impossible. So it is really a difficult thing to design a new trial and at the same time overcoming all the right critiques that were given by the discussant. So it's very difficult to do that. So if we want to do that, it will have to be collaborative, very standardized. I mean, we need to learn from what we have learned here, but let's try at least. And what Dr. Flake says, it doesn't help to do many balloons if we don't learn from it. And certainly not in unprepared hands. Don't forget, this can kill a baby.
Okay, so I'm going to ask another couple of questions, but just one comment here. And I think you probably answered this, Dr. Flake. How can you translate the trial results to your center? I think there's probably quite a lot of learning to be done from that trial, which is, I think you've already implied that in terms of preparing you for your trial. Yeah.
No, I agree. And again, I think if you have higher survivals and that is maintained, as in our center, then I think you have to look at morbidities, and those are very worthy targets to look at. The morbidities are terrible, and they have long-lasting consequences for the infants and families. And so I think morbidity is going to be the ultimate target that makes the intervention so worthwhile if it impacts those.
Okay, and I'm going to ask three more questions actually. Do you see a difference in perinatal outcomes in developing countries treating severe CDH cases with FETO?
I only can speak on what I know from the literature, and this was already mentioned by Dr. Ruano. So the survival rates with expectant management during pregnancy in severe hernia are apparently lower in some countries. But that's probably also not the place in the world where you want to do fetal therapy to push that up. I mean, the most logic thing is that you try to work on the postnatal side. On the other hand, I think also those patients should not be excluded from it. So in those centers, they may have to run their own statistics. But if you have very, very low survival rates, I mean, I would first invest in the postnatal management protocol and not use the gimmick of fetal therapy to try to address that. But indeed, they may have their own statistics, as actually Europe may have different statistics from the USA.
But I couldn't agree more with that answer. You know, the neonatal care needs to be adequate to support a very, very sick baby, or it's not worth putting a balloon in. Our severe diaphragmatic hernias that receive balloons are still extremely sick, and they require a lot of sophisticated care. And so in a developing country, that won't be present.
Yeah. And Jan, I'm assuming that you're going to follow up your cohort so that you can get some idea of the morbidities. Yeah.
Yes,
okay.
indeed.
Now this is a more challenging one. So I'm interested to hear which ethical tensions you identify with fetal surgery or other types of fetal surgery, especially in relation to expectant parents' decision making concerning NIPT or other types of prenatal screening. So, I mean, are you going to be I think that question is relating to, are you going to be treating patients or fetuses who have got a genetic abnormality, or would you exclude them from your?
At this stage, this is definitely not our strategy. I think the whole concept of fetal therapy is that you have a certain diagnosis and a predictable natural history. So if we want to modify the natural history, it becomes difficult to interfere or to start treating fetuses where you actually don't really know what the outcome will be. That doesn't mean that there are no limited structural defects that may be eligible. I mean, we had this debate last year at the ISPD, this very interesting debate with Spina Bifida. I mean, we should not be, during the times that it is not level 1 evidence supporting the therapy, but know that you have this, you must be in limited conditions considering patients with additional abnormalities that will not influence that natural course. And that can be treated after birth, but not randomly, of course, treating anything. Eh?
Alan, would you support that?
I agree with that completely. And you know, when you have other thunderstorm going on the side, if you have other complicating factors that impact quality of life in your outcome that are relatively unpredictable or predictable in the case of trisomies, etc., then I think it impacts the benefit to risk ratio of what you're doing, and you have to consider that and counsel in that regard.
And one final question for both of you, really. This is a look into the future. So how do you anticipate the scenario in fetal centres offering FETO will be in 5 years from now? And any thoughts on how to reduce the morbidity for centres who do not have much experience? Alan, let you go first on this one.
Well,
where will you be?
I hope that FETO will be limited to high volume centers with experienced fetal therapy teams and experienced fetoscopists. And I think those were the qualifications for entry into Jan's trial. And you had to do a certain number of FETOs under their guidance and with their help in order to be qualified to enter into the trial. I think That's how you avoid morbidities with the procedure, is you seek appropriate training in it. You maintain oversight for your first several cases. And obviously you have the experience as a fetoscopist to begin with to do these procedures. So that would be my hope in the future, is that the quality is maintained and the morbidity minimized by the selection of people that do it and decide to do it.
So you can do that for the procedure, actually the FETO procedure, but I mean, in your trial, Jan, you had at least one case where the problem was with removing the balloon. So, and if you're going to be doing this in large centers, people are going to travel, aren't they? And probably long distances to have this done. So that aspect is going to be difficult to account for. But Jan, what do you think?
Yeah. So, well, the procedure as it is today is it's a very big difference with other fetal procedures. It is a non-elective procedure. The insertion is, but the removal is not. It comes unexpected, 1 out of 5 in difficult circumstances, and that is when it can go wrong. I think the reporting here was very clear and honest. There was a balloon removal problem in so-called experienced hands. So that is what needs to be addressed. As you know, we are working on a balloon that would make removal much easier, which could have as a sub-consequence that we shoot ourselves into the foot, because then people will say, well, if it's that easy, we will start to do that. That should, of course, not happen. The other thing that I think will change in the future is this is not a very good fetal therapy, because survival goes up to 50%, goes up to 67%. We need to do better. So we are definitely considering, and this is a collaboration that Dr. Flake and myself have, is on medical adjuncts that you can add to the fetal therapy, so that which at least in animals empowers the effect of tracheal occlusion. So that is what I think we will change in the next 5 to 7 years. And if we have medical adjuncts, of course, that will make the therapy more accessible, because anybody can give medical therapy.
Okay, I'm going to end it there, and I'd like to thank you very much. Jan, thank you and congratulations on delivering a mammoth task. Actually, all of us are very impressed with the staying power you've had to see that through over the length of time. And Alan, thank you very much for your discussion, and good luck to you in your trial. And I hope it doesn't take you 10 years, but hopefully you won't. And I hope you both, well, you're obviously working together, and I think this is great. And I think the collaboration and multi-center nature of the work here that you've demonstrated is fantastic. So thank you very much indeed. And I'm going to end the conference now. That's all the time we have for the Q&A. And that session concludes this year's virtual conference, our first virtual conference. I hope you've enjoyed it. I certainly have. We've had a great array of really good speakers and lots of participation and a huge number of posters. So thank you all for your contribution and for your discussion. I'd like to thank all of our presenters and the discussants, along with our exhibitors and supporters. And the recordings from this conference will be available for the next 30 days. The live Q&A, and I think the last Q&A here is particularly educational and useful, will be added to the platform within a week. So the live Q&As will be added to the platform so you can share them and read them, listen to them again. So if we have the next slide, please, I hope that you will save the dates and make plans to join us for our 26th International Conference in Montreal. I sincerely hope that we see you face to face, because I very much welcome the opportunity to meet you and to do the networking that goes along with face-to-face meetings. So be sure you check the ISP website for more details as planning progresses. And once again, thank you very much indeed for your attendance. And I would be very grateful if you would feedback the questionnaires, which Paige and the ISPD team will distribute. So thank you very much indeed, and goodbye.